In previous videos we have seen all characteristics of normal sinus rhythm. Let's see last characteristic of normal sinus rhythm, which is normal QT interval. As the name suggests, QT interval is the distance between Q and T waves. It is measured from start of Q wave till end of T wave. That means it represents time duration of depolarization and repolarization of ventricles. When heart beats faster, ventricles depolarize and repolarize faster. It shortens QT interval. Likewise, slower heart rate causes slower contraction and relaxation of heart, which prolongs QT interval. Now let's see significance of long and short QT interval. Abnormally long or short QT interval is associated with an increased risk of abnormal cardiac rhythm and sudden cardiac death. As QT interval changes with heart rate, it becomes difficult to compare QT intervals measured at different heart rates. Hence calculated QT is seen. QTC estimates the QT interval at a standard heart rate of 60 beats per minute. It adjusts the QT interval correctly at heart rate extremes. Nowadays, almost all ECG machines automatically calculates and prints QTC on ECG. Normal QT interval is less than half the preceding R interval. Normal QT interval in men is between 350 to 440 milliseconds, and in females between 350 to 460 milliseconds. QTC is said to be prolonged if more than 440 milliseconds, and if more than 500 milliseconds it is associated with high risk of torsade de Pointes. We will discuss torsade de Pointes at the end of this video. Less than 350 milliseconds QTC is said to be short QTC. Causes of prolonged QTC are hypokalemia, hypomagnesemia, hypocalcemia, myocardial infarction, ROSC post-cardiac arrest, which means return of spontaneous circulation post-cardiac arrest, raised intracranial pressure, congenital long QT syndrome, and some medications can also cause prolonged QTC. In this picture you can see how hypo and hypokalemia changes ECG. Serum potassium level below 3.5 ml equivalent per liter is considered as hypokalemia. Causes of hypokalemia can be of gastrointestinal origin or renal potassium loss, or it can be due to shift of potassium from extracellular to intracellular space because of some reason, for example alkalosis. Prolongation of action potential duration in hypokalemia is due to inhibition of the outward potassium current. As the serum potassium levels fall, the T waves become flattened and may disappear, and the U wave becomes more prominent as hypokalemia worsens. This in effect will produce an apparent prolongation of QT interval, though it is actually the QU interval which is often manifest. In hypomagnesemia, hypocalcemia also long QTC interval is present. In raised IC pressure, also you may see prolonged QTC along with T inversions in multiple leads. In hypothermia you will see artifacts on ECG due to shivering, Osborne or J wave, prolonged QT interval and T inversions. In medications, antidepressants like amitriptyline, nortriptyline, citalopram, escitalopram, antipsychotics like haloperidol, droperidol, quetiapine, olanzapine, amisulpride, antiarrhythmic drugs like flecainide, quinidine, procainamide, sotalol, amiodarone, antihistamines, loratadine, and antibiotics like erythromycin or clarithromycin can also cause prolonged QT interval. As we know, an abnormally prolonged QT is associated with an increased risk of ventricular arrhythmias, especially torsades de Pointes. Torsades de Pointes, TDP, is a specific form of polymorphic ventricular tachycardia, occurring, in presence of QT prolongation, produces characteristic QIS morphology, in which the QIS complexes twist around the isoelectric line. Ventricular tachycardia VT can be of two types, monomorphic and polymorphic. VT is the tachycardia which arises from ventricles. When multiple areas in ventricles generate signals, you will see different shapes of QIS complexes with different amplitude, axis and duration. It is named as polymorphic ventricular tachycardia. If one focus of signal generation dominates others, you will see single type of QRS complex. It is named as monomorphic ventricular tachycardia. The most common cause of polymorphic ventricular tachycardia is myocardial ischemia or infarction. Torsades de Ponce is the result of QTc prolongation, which can either be congenital or acquired. Acquired QTc prolongation is most often drug-related. There is an extensive list of medications, like antiarrhythmics, antipsychotics, antiemetics, antifungals, and antimicrobials that can cause torsades. For torsades de Ponce to be diagnosed, the patient must have evidence of both polymorphic VT and QT prolongation. Torsades de Ponce is often short-lived and self-terminating, however can be associated with hemodynamic instability and collapse. It depends upon the underlying cause. It may also degenerate into ventricular fibrillation, VF. QT prolongation may occur, secondary to multiple drug effects, electrolyte abnormalities, and medical conditions, or multiple factors, may combine to produce torsades de Ponce. For example, hypokalemia may precipitate TDP in a patient with congenital long QT syndrome. Recognition of torsades de Ponce and the risk of torsades de Ponce should be our priority in suspected cases. We should closely monitor ECG changes and electrolyte values frequently, and specific management strategies should be applied like potassium or magnesium correction, isoprenaline, or overdrive pacing, etc. We will see more details, why premature ventricular contractions, PVCs, occurs, and what is our on-T phenomenon, later while discussing specific arrhythmias. What I expect from you is active participation, likes and comments to appreciate efforts. Short QT interval is caused by hypercalcemia, digoxin effect or short QT syndrome. In this example you can see short QT, an Osborne wave in hypercalcemia patient. Short QT syndrome may be suggested by the presence of long atrial fibrillation in young adults, family member with a short QT interval, family history of sudden cardiac death, or ECG showing QTc less than 350 milliseconds with tall, peak T waves, or failure of the QT interval to increase as the heart rate slows. That is why proper and detailed history is always important in critically ill patients. Digoxin produces a relative shortening of the QT interval, along with downward sloping ST segment depression in the lateral leads, reverse tick appearance, widespread T-wave flattening and inversion, and a multitude of arrhythmias. We have completed characteristics of normal sinus rhythm here. In next video, we will wrap all parts of characteristics of normal sinus rhythm in one, and then we will proceed further to discuss emergencies in ICU. If you want me to make video on any specific topic, comment below. Thanks.